Welcome back everybody. So in this next video we are now going to talk about rapidly progressive glomerulonephritis, sometimes also called crescentic glomerulonephritis because of a common finding in this pathology. So first we're going to talk about the pathophysiology. So as with our previous conditions, we get damage or dysfunction of the glomerular basement membrane, which ultimately leads to a leakage of cells and proteins that causes an increase in cytokines and an immune reaction, leading to a fibrin clot formation and cellular proliferation. And this is where the name crescentic actually plays a role. So let's break this down and talk a little bit more about this pathophysiology. The tricky thing about this pathology is there are a variety of different things that can cause this presentation. But what's fairly consistent is this idea of crescentic shape formation on the renal biopsy. So essentially, if we have our glomerulus, we know that in a healthy filtration system, we're only allowing small molecules such as water and ions to pass through. However, if we have damage to this filtration system, now we might also see a leakage of much larger molecules, which I'm drawing here in green, passing through our barrier. So these larger green molecules passing through our now damaged barrier can include things like plasma proteins, fibrin, or inflammatory molecules. This can also include other things such as epithelial cells, and essentially the combination or the release of these molecules and the proliferation of our epithelial cells creates a classic crescent-shaped structure in the glomerulus. And that's what we can see when we're working up patients and we're looking at our diagnostic criteria is this crescent moon shape on light microscopy. I put a high yield here because this is an important word to understand the crescent formation with rapidly progressive glomerulonephritis, but it's also important to know this image right here where I want you to appreciate on the outside we have a large crescent appearing structure, which I'm drawing here in green. And so if the red circle was kind of our normal area for where our glomerulus was originally, the release of all these molecules and the expansion in this crescent shape highlighted here in green shows that this patient likely has rapidly progressive glomerulonephritis with the classic crescent shapes being shown. As we said, these crescents contain a variety of different molecules, including fibrin, macrophages, plasma proteins, and parietal or epithelial cells. So in general, this is an overview of the condition where you get this classic presentation, but we can then break it up into different types. And the ones we need to know for right now include type 1, type 2, and type 3, and being able to distinguish the different pathologies that can cause these conditions. So if we look at type 1, I want you to really focus on the word linear. And this linear presentation is due to anti-glomerular basement membrane antibodies that bind collagen. And the classic pathology here is Goodpasture syndrome. So recall, in Goodpasture syndrome, the most commonly affected organs include the lungs and the kidneys. But how this happens is that we have autoantibodies, and these antibodies will bind to the glomerular basement membrane in a linear fashion, ultimately activating the complement system. This is a type 2 hypersensitivity reaction, but the key here is to know that it's a linear immunofluorescence pattern because of where it attaches. It attaches to the glomerular basement membrane, specifically to the alpha-3 part of the collagen chain. And so because these are anti-glomerular basement membrane antibodies binding, they present in a linear fashion, but we can compare and contrast that to our type 2 presentation, which is going to present with a granular appearance. This is due to immune complex deposition. Remember, an immune complex involves an antibody bound to an antigen that then goes and kind of randomly deposits itself in the glomerulus. And that's why you get a granular appearance, because it's not as symmetrical. It's not just the antibody going to the basement membrane. It's an immune complex being delivered to the glomerulus and basically depositing wherever it finds a spot. This is more commonly associated with some pathologies including post-strep glomerulonephritis, diffuse proliferative glomerulonephritis, and IgA nephropathy. So in summary, for type 2, we have an immune complex, not just the antibody itself, which will then go and deposit at various places throughout the glomerular basement membrane, creating this granular appearance. And finally, for type 3, we say that this is negative or posse-immune, meaning there is typically not antibody or immune complexes involved in this pathology. This is most commonly associated with granulomatosis with polyangiitis, eosinophilic granulomatosis, or microscopic polyangiitis. So we would not expect to see immunofluorescence if the patient had rapidly progressive glomerulonephritis due to these pathologies. Why? Because the pathophysiology that is creating this presentation in the patient is not involving antibodies or immune complexes, and thus there's nothing to essentially light up. There is no immunofluorescence that would be expected. So then you might be asking yourself, well, how do you tell these conditions apart? Well, there's another key lab that we have to use called the ANCA. And if you recall, granulomatosis with polyangiitis is associated with C-ANCA or the PR3 ANCA, whereas eosinophilic granulomatosis and microscopic polyangiitis are more associated with P-ANCA or the MPO ANCA, with the MPO standing for myeloperoxidase. And so the key with differentiating these different types of rapidly progressive glomerulonephritis is with the vignette or the presentation of the patient. So in type 1, we said it's a linear immunofluorescence. This is often going to present with a patient who has both lung symptoms and renal symptoms such as Goodpasture syndrome. So if a patient is presenting with renal deficiencies and they mentioned they're having hemoptysis, cough, dyspnea, indicating there's also a lung involvement, I want you to be thinking about Goodpasture syndrome. Additionally, if they gave us an image showing linear immunofluorescence, we would also be thinking about this type 1 rapidly progressive glomerulonephritis. Remember, type 2 is going to be more of a granular appearance because this involves immune complexes or an antibody bound to an antigen, which would bind in a more randomized way than our type 1, which is purely an antibody binding to the glomerular basement membrane in a linear fashion. And for type 3, I want you to remember that you wouldn't see immunofluorescence, and the reason is because it doesn't involve an antibody or an immune complex, and thus there's nothing to essentially light up when we do an immunofluorescence test. The key way to differentiate these is by looking for additional information in a question stem, such as a P ANCA or a C ANCA. Next, I want to move on to the management options for these conditions, and the main thing we have to offer is immunosuppression, such as glucocorticoids or cyclophosphamide. And this should make sense to you because these are immune-mediated responses, right? So if we calm down the immune system, potentially we can help improve the patient's prognosis. We can also consider things like plasmapheresis to really help remove some of those antibodies from the serum, which are causing the problem. They're causing the kidney pathology. Overall, it's important to note, and the reason why I said we can give them immunosuppression to try and improve their prognosis is that these patients typically have a poor prognosis. That is to say, rapidly progressive glomerulonephritis, as the name suggests, is associated with rapid destruction of the kidney. And because it's rapid destruction, the overall prognosis for these patients is not very good. So in summary for this video, the key points I want you to take away here is that, again, the pathophysiology, as with all of the other conditions, it involves damage to our filtration system. Specifically here, we see these crescentic shapes. The reason is that we have the leakage of all of these substances over here, and the deposition of these substances leads to a classic finding of a crescentic moon shape on light microscopy. It's also important to note that we have 3 different primary types, right? We have the type 1, which is linear. Oftentimes they're asking about Goodpasture syndrome, particularly if they mention lung involvement in addition to renal involvement. Type 2 is granular, which typically involves post-strep glomerulonephritis, diffuse proliferative glomerulonephritis, IgA nephropathy, or other things that create an immune complex deposition in the glomerulus. And finally, type 3 is our negative immunofluorescence or posse-immune, meaning that it is not involving antibodies or immune complexes. This involves a variety of different pathologies that we could then get further testing on to look at whether or not the patient has a positive test for P ANCA versus C ANCA. The management of this condition involves immunosuppression, potentially plasmapheresis, or other symptomatic management to prolong the deterioration of the kidney, but ultimately this does have a poor prognosis as we will see rapid destruction of the kidney.